everyone. Stephanie Carmody. I know most of you. I'm so excited to have this session today, and excited for Dr. McCray. Some updates. He's going to have a presentation first for about 30 minutes, and then after that, we'll open it up to questions. You can ask, get the chance, or since everyone has the chance to be on camera, just raise your hand, and I'll call on you. And let's get started. Take it away.
Oh, great, thanks, Stephanie. Thanks for organizing this.
You're welcome.
All right, so share screen. There we go. Guys, able to see the slides?
Not quite yet. Yep, there we go.
All right, great. Okay, so back in December of 2020, I think is when I spoke to Stephanie's Facebook group before. So a lot of these slides are similar. So I apologize if a lot of this is, if people were at that meeting and some of this may be the same things over and over again, but there's also updates kind of mixed in, and I wasn't sure how many people would be on this meeting that hadn't heard me talk about this before. So, and I'd say, you know, if people have questions as I'm going, I can try to answer them. So this is kind of what I'm going to go through, some of the clinical features that we see with TRPV4 mutations, some basics of what TRPV4 does in the body, and then go through some of our work on fly models and mouse model that we've created along with Charlotte Sumner's lab to try to understand TRPV4 neuropathy better. And then how we're trying to use our insights from the mice and flies to try to get to a clinical trial. Some of the early results of what we've gotten with analyzing a number of different people who have been generous enough to enroll in this database. And then, you know, as I said, I can try to answer questions as we go, but then I'll have time, hopefully at the end, to answer more questions. So as probably most of you are aware, TRPV4 mutations cause kind of a range of different kinds of neuromuscular conditions. So I call them TRPV4 neuropathy, but even that is not such a perfect term for this range of conditions. And so there's, I think a lot of people get a diagnosis of CMT2C. And generally we think of this as a condition that has both some element of weakness and some element of sensory loss. Some people that have mutations in TRPV4 only have weakness without sensory symptoms. And often the weakness can be sort of unusual as compared to other forms of certainly CMT, because there can be what we call proximal weakness, weakness more of muscles near the core, so near the shoulders or near the hips, whereas most kinds of inherited neuropathy generally affect the feet and hands more so than those other muscle groups. And then there's also, seems to be a congenital form where that is a term meaning that symptoms are present at birth. And so I think a lot of people in the Facebook group in particular have children that are affected with the congenital onset form. And so these three types are kind of described in the literature, but there's probably a good degree of overlap, and the distinctions between these are probably not as clear cut as we like to sort of think they are. And there's a lot of other unusual features of TRPV4 mutations with respect to other genetic neuromuscular conditions. So it is a dominant disease, meaning that for all the cases we know of at this point, if you get one disease-causing mutation in one copy of the disease of the gene, that's enough to cause disease. But there's a lot of variability, even among families. Some people can be really severely affected. Some can almost have no symptoms completely or almost no symptoms that we can only pick up if we really take a close look. We don't really understand why that is. It doesn't seem to be the nature of the exact gene mutation, because the same mutation can cause a whole range of manifestations. So this picture on the lower right is actually a mother and daughter with the same mutation, and they're clearly very differently affected. And then there's this somewhat unusual feature also of frequent vocal cord weakness, and sometimes weakness of the diaphragm, the main muscle that helps with breathing. And then something called scapular winging, and also problems with the skeleton. So I wanted to talk more about vocal cord weakness, because I think Charlotte Sumner and I are becoming more aware of this and more interested in this for a number of reasons. I think my guess is that it might be one of the more problematic things that you all have to deal with, which is obviously important to know as physicians, but also important to understand more if we're thinking about someday doing a treatment trial. And so the vocal cords are these kind of pearly white things. I don't know if, can you see my cursor when I move around? So these sit kind of at the base of the tongue. They open with normal breathing, and they close and sort of vibrate with speaking. And so this is a video of someone sort of singing. And so you see when they take a breath in, they open, and then this is sort of a trick that they're sort of moving in slow motion because of this trick that the laryngoscopist is doing, but that's essentially what happens with normal singing, speaking, and breathing. And so what happens with TRPV4 mutations is often the vocal cords, either one or both, can get weak or can get paralyzed. And so that can basically cause a narrowing of the airway. And so air has a smaller space to get through. And that can lead to these kind of loud breathing, which we call stridor, particularly with breathing in. And so that can be, really important, I think, for quality of life, but it's also something that we want people to be aware of, because if there is a narrowing, and then on top of that, there's something that causes swelling, like an infection, an upper respiratory infection, that can make the airway suddenly even more compromised, and that can be really life-threatening and dangerous. So it's something that all of you that have mutations should know about. I don't want to scare people, but it's just something to be aware of. So other manifestations, I mentioned the scapular winging. And so this is shown here in this picture, this kind of bowing out of the shoulder blade muscle. And this is because of weakness of the muscles that normally should be holding the shoulder blade in place. And this, again, is not something that's typical in other forms of CMT, but something that can happen fairly frequently with TRPV4 mutations. And that can affect kind of the ability to lift your arms up at the shoulders. And then there's a number of changes in the skeleton that can happen. There's the kind of classical things that happen with other forms of CMT, foot deformities, these high arches and pes cavus, but then we're increasingly seeing other skeletal manifestations like problems in the hips. And someone in the last session mentioned this, particularly arthrogryposis, which is a term for congenital joint contractures, basically joints being fixed in an immovable position. And that's something that unfortunately we also see with TRPV4 mutations. And then we suspect there may be other things we don't know about, but one of them that has been described is hearing loss. From the last meeting we had with this group, we've sort of learned of a new one, which I'm still learning about, but this tethered spinal cord, which seems to be a real manifestation, at least in some people. I don't know how frequent it is, but it definitely seems to be correlated with TRPV4 mutations. And then, we hear sometimes other things, and we're not sure whether those are common or not, but it's something we're trying to learn more about, other potential manifestations that go along with these mutations. So there's even a paper with a sort of rare TRPV4 mutation where the patients had what they called scaly skin. To my knowledge, I haven't heard of this as being a general thing, but it's something that's kind of on our radar now. So in addition to these kind of neuromuscular nerve diseases, manifestations I described, there's also different mutations in TRPV4 that cause pure bone problems. These are called skeletal dysplasias. And for the most part, we used to think that you got one of these and not the other, but we're increasingly seeing that there is a degree of overlap. And it's something that I think people who see bone disease, they're not good at picking up neurological symptoms, and certainly I am not good at picking up skeletal problems. So I think we need to put our heads together and work together more to try to understand how much overlap there really is. So I wasn't going to go into a lot about management and testing and things like that, but this Gene Reviews article that Charlotte and I wrote with a few others, I think is a good resource. And it's, if you're most likely if you're seeing someone who's not an expert in TRPV4, which there aren't many people, this is a good resource also for treating clinicians who may not be that familiar with TRPV4. So I want to talk a bit about basics of how the channel works and how we think it's going wrong in disease. So TRPV4 is expressed throughout the body. It's not expressed in every cell. It's actually not that expressed in the nervous system, not in sensory and motor nerves actually, which is surprising, but it's expressed throughout lots of different tissues. One of the things that we think may be critical is its expression in blood vessels, in the walls of blood vessels, but it's also in kidney, bladder, certainly in bones. And it's an ion channel that sits on the surface of cells. So this is what it looks like, sort of in a three-dimensional image, and there's sort of a hole in the middle and things can go through that. And so what we know from studying TRPV4 in the lab is that mostly what TRPV4 allows to enter cells is calcium. And the mutations that cause disease basically increase the opening of the channel or change the way that it opens in some way such that there's more calcium flowing into the cells than there would be otherwise. And whether the mutations cause skeletal dysplasia or cause neuropathy, it seems to be that they always increase calcium influx in some way. And so what that really means is that if this is really a central problem, too much opening of the channel, if we block the channel, that should, in theory, be something that could be therapeutically beneficial. And so one of the reasons we're, really excited about this project and this possibility is that there's already at least one drug out there that's been tested in people and shown to be safe. And this is this GSK 2798745, which GSK calls 745. And this is basically a pretty good, specific, safe drug, and it's a pill. And right now, it's a good drug that's in need of an indication for how to use it. And so GSK has been looking for conditions that this could be used to treat, and so far they've struck out. They've tried it in chronic cough. They've tried it in kind of lung pulmonary edema. It's called a sort of increased fluid in the lungs. It didn't work in either of those situations, but it was safe in those patients that received it. So we're hoping that this might be something that could be useful for those of you that have TRPV4 mutations. So to try to get there, we've been, so Charlotte Sumner, who I work with closely, was one of three labs that initially discovered TRPV4 mutations in neuropathy in 2010, so over 10 years ago now. And so we've been trying to learn a lot more about it so we can kind of move things towards a clinical trial. And so some basic questions, why does overactive TRPV4 cause disease? What cell types is it doing this in? What part of the body is affected? And so it turns out, I mentioned mutations in TRPV4 can cause either forms of spinal muscular atrophy or Charcot-Marie-Tooth disease. And while those might look fairly similar, might cause similar symptoms, the implication is actually that the problem is in very different places. So in spinal muscular atrophy, the problem is really the motor nerves, the nerves that start in the spinal cord and go out to the muscles. So the problem is really usually in the cell where it sits in the spinal cord, whereas in CMT type 2, usually the problem is in the axon of the nerve after it has left the spinal cord and as it goes out towards its target muscle. So that's kind of a fundamental difference that we're not even really clear on in terms of TRPV4 and disease. And then what happens downstream of these mutations? So we think calcium levels go up, but where is that important? What does that do? How does that lead to the different manifestations of the disease? And then a really critical question, can we block it? Can we fix, the disease process? And, how would we know if that's working? And, how could we really prove that and show a benefit for patients? So for that, we've turned to a couple of different animal models. The basic strategy is take the human mutations that cause disease and put them into either flies or mice. And the less dramatically you can change the organism that you're studying, the better. So you can kind of express a lot of the disease gene and cause disease that way, or you can just make one tiny little change to mimic exactly the same kind of change that a patient would have. And that's what we've tried to do, at least with the mice. And so in both cases, if we put in mutant TRPV4 in flies or mice, we get signs of neurological problems. And then that allows us to really study what's downstream of that, help us understand, what tissues seem to be affected in the disease, and really understand the basics of what's going on downstream, and then certainly allows us to test whether we can fix the problem in the ways that we expect we might be able to. So this is the fly model that was generated in Tom Lloyd's lab, who's another researcher at Johns Hopkins. So this is basically a fly larva, a little maggot. We don't like to call them that because it's not a very nice term, but basically what we do is we put TRPV4, the mutant form, in there, and it causes degeneration of here. These are the axons, and these are the dendrites of the nerve cells. So either in the body wall or sort of the equivalent of the fruit fly brain. And so putting in the mutant form causes these to degenerate, and we can treat with this TRPV4 antagonist. So this is not the same one that I showed in that clinical trial, because that one is not available, but this is sort of like an analog of that drug, and we can rescue the degeneration in these flies. We've also looked at a number of other things that happen downstream of TRPV4 activation and other things that might be involved. And one of the ones that we published recently is this protein called RhoA. And so normally TRPV4 is supposed to kind of bind to RhoA, and the mutations block that binding and they cause increased activation of RhoA. And so with that, and then if we inhibit RhoA, we can also rescue these flies. So we can improve the degeneration of these axons and the dendrites. And so this doesn't have as much immediate relevance to treatment of those of you that have TRPV4 mutations, but in the broader context, this fits with this idea that we're starting to have more and more that TRPV4 might be kind of a switch that's doing bad things in a lot of different conditions in which nerves are damaged. Because it's known that RhoA is kind of something that gets activated in a lot of different situations where there's damage, like stroke, spinal cord injury, traumatic nerve injury. And so we think we're starting to get a sense of not only what happens with TRPV4 mutations, but maybe where TRPV4 is kind of being a bad actor in other situations. And so that led to this kind of complicated model of how TRPV4 mutations might be affecting RhoA and how that might be having an impact on neuron health and health of other tissues. So other things that we're doing in the lab, trying to address other important questions, is with genetic testing being so common now, it's a large problem that when we have all these 100 different genes that we know can cause different inherited neuropathy phenotypes, we get a lot of kind of genetic noise. We get changes in genes where we don't know whether they cause disease or not. And so it's really hard to sort of sort those out. And so what we're doing in the lab is testing a number of different changes in TRPV4 to see whether they cause the kind of typical problems with opening of the channel that the known disease-causing mutations do. And so this is just to give you an example of that. So this R269C change is one of the common ones. And when we put that into cells, we look at calcium, we see that calcium levels go up higher than they do for the normal TRPV4. Some variants we've looked at don't seem to cause this change. Some are sort of in the middle, and then there are some that are clearly behaving like the disease mutations that are very well validated. So this is kind of a way to try to sort through some changes that might be out there that some of you may have seen on genetic testing reports, and try to decide. Some of you may have seen variant of unknown significance, and so we're trying to sort through that in a more of a systematic way. And we can actually, based on these results, kind of start to map where on TRPV4 mutations seem to be a problem. So these red ones are the ones we know cause disease, and then some of these green ones are changes that don't seem to cause disease. And so we're kind of getting a sense of which parts of TRPV4 are really important for causing disease. So the other thing that we've been doing is this TRPV4 patient registry. And so the purpose of this is really to try to get towards a clinical trial. But there's some real barriers to that. And if many of you were on the larger meeting, you heard about a lot of those, and they really stressed the importance of these natural history studies. And so we need to understand more about just sort of the normal core features of the disease, but also what happens over time. And then probably for a clinical trial, what we really need to hone in on is people that are getting worse. So some people seem to not get worse, which is great. And then some do. And so those are the ones that are going to most likely probably show a benefit in a clinical trial. And so this project is being run through the Inherited Neuropathies Consortium, which is a global effort to understand and enroll patients with different types of CMT and learn more about them. So there's a number of sites in the United States. There's a big site in Australia, United Kingdom, and in Italy. And so there are already a number of people in the database that we've been able to analyze, and we're also trying to boost those numbers. And the idea is to try to look at the clinical records, neuropathy scores, et cetera, to try to understand the progression of the condition. And the other big thing that we're trying to do is distribute a TRPV4 specific patient questionnaire to everyone that gets enrolled. And so the reason is that I've been telling you how unusual TRPV4 is compared to other forms of CMT and inherited nerve diseases. And so the Inherited Neuropathy Consortium database was really designed to capture things that are important for sort of typical CMT, but it's not really great at capturing what's important for TRPV4 patients. So that's what we're trying to get at with this questionnaire. So as of last week, this effort is finally fully approved. So it's been a long, slow, not terribly painful, but slow process. There's 30 people already enrolled in the INC, and then a number of you from different places have reached out to me over the past year to say that you wanted to participate. And so we're going to now ramp up our efforts to send the questionnaires out to those that are already in the INC, and then enroll people who want to be enrolled. And then that will also go along with this TRPV4 questionnaire. So the other things we've established is a TRPV4, what we're calling a channelopathies clinic at Johns Hopkins. So the reason we call it channelopathies rather than neuropathy is because some people only have skeletal manifestations and not neuropathy. So we want to be able to capture kind of everyone that has a disease-causing TRPV4 mutation. And so what we've been able to do at Hopkins now is assemble a team of ENT physicians that can do vocal cord assessments along with a typical visit on any day that someone's able to come. We're also going to have ophthalmology evaluations, as we think there's a possibility that there may be some not symptomatic changes in the eyes, but maybe something that can help us in a clinical trial. Orthopedics to look at skeletal manifestations. So we have this sort of team assembled now that can really provide, I think, the opportunity to learn more about TRPV4 neuropathy and skeletal dysplasia, and then also give us the chance to do biomarker studies. And some of you may have heard a lot about that in the conference today as well, which is a term basically for a way to monitor disease progression, disease activity, and certainly, the idea is usually to be able to monitor the effectiveness of a treatment before you start to be able to really see the improvement in strength or sensation. It's kind of an early marker of disease effectiveness, treatment effectiveness. And so we're doing a number of things to try to establish biomarkers. So, so for those of you that wanted to enroll in the database, there's options of either doing that in an in-person visit at one of the participating INC centers. There's only 20 of them in the world, so it's not, probably a lot of you are not close to one. So a lot of people have chosen what we're calling the virtual option, so we can do most of this enrollment over the phone. We can send you a questionnaire in the mail, and then we can, because of COVID, we've actually established a new protocol to do an exam virtually by video. So that's one option. For anyone who can come to the clinic at Johns Hopkins in Baltimore, I would really encourage you to do so if you think it's safe and you can actually pull it off. Because I think we can get a lot of information from face-to-face visits with this new channelopathies clinic. But any way that anyone wants to participate, it would be fantastic. And anyone who wants to participate and knows of family members or is it involved in any group of other people that might want to enroll, please feel free to reach out to me or our study coordinators, because we're always trying to recruit more patients. So from the early analysis of the data we have, I can say at least a few things that might not be surprising to people who are living with this. But one thing I think this was surprising and good is that if we look at all the patients that have type 2 CMT in the inherited neuropathy database, TRPV4 mutations are not quite as rare as we thought they were. So it's actually way behind CMT2A, which is by far the most common, but only one other mutation is ahead of TRPV4 in terms of prevalence in this database. So we're still talking about low numbers, but this is not, the absolute lowest frequency on the list. So there's a reasonable chance that there's a lot of people out there that have mutations that we haven't identified or that could potentially get involved in this research if they're so inclined. The other thing is we're able to kind of see the distribution of mutations in TRPV4. So most of the neuropathy mutations that have been characterized and that are clearly disease-causing cluster in this anchor and repeat domain, shown here, these blue kind of blue coloration here on this structure. And in the database, 90% of all the mutations that are identified are in this anchor and repeat domain. And then this is the breakdown of specific mutations. So this R269C, which we've always thought was the most common, is a tie with R316, which can be either C or H. Some of the other things we see if we compare sort of typical CMT, which is CMT1A, to TRPV4, there seems to be a lot more proximal weakness, so of the hips and shoulders in TRPV4 patients than in those with CMT1A. So more symptoms above the elbows, and then more symptoms kind of in the hips than in CMT1A. So this just kind of emphasizes that TRPV4 mutations are different than classical CMT. And if we ask those of you that have TRPV4 mutations, it's 70% of you say you don't have any sensory symptoms, numbness, tingling, things like that. But when we do an exam, we do see, at least with vibration, that there is some sensory involvement in a much higher percentage than that. So sort of the symptoms seem much less than in CMT1A, but the actual vibration changes on exam look about comparable. So I think there may be some subtle sensory changes that are present that might not be symptomatic, which is just, I'm glad that they're not symptomatic, but it's suggests maybe that there's a little more sensory involvement than might otherwise be predicted. And then this is very early kind of analysis of neuropathy scores over time, but there's quite a bit of difference in the progression, which is kind of what we knew going in, which makes things a bit challenging. But some people can have essentially no progression, very mild disease over many years. Some have kind of a ramp up of worsening, and others are sort of, kind of within the noise of these tests, bouncing around, but kind of generally moving up a little bit. So, so that's the kind of work that we're trying to really ramp up with the patient registry. So I think that's, all I have for now. I wanted to thank certainly everyone who has been participating in our research, and in particular, Stephanie has been fantastic. We wouldn't be where we are with these efforts without her. She's been really, really helpful and kind of connecting the two communities of the people who are working on this in the clinics and the lab with the people who are living with it. And then we have our clinical research support team that some of you may be hearing from soon to get enrolled in these studies. And then I mentioned Charlotte's lab, particularly Jeremy Sullivan, and the Lloyd lab has been really pushing this work forward. So I'm kind of the face of this work for today, but it's certainly not by any means my work, exclusively.